We move to the second clinical case. Laurie?
Thank you, Laura. And I am happy to say that my case has just 2 slides, so we will be able to finish up on time. So this is, and the reason for just 2 slides is this is a patient that we recently met in clinic. He's a 74-year-old man who presented to an outside hospital with chest pain. A chest CT was done in March, showing a very large left thyroid mass going down into the mediastinum associated with tracheal deviation. And also there was tracheal infiltration appreciated on the CT scan. There were several enlarged peritracheal nodes up to 2.2 centimeters, extending to the level of the aortic arch on the chest CT scan. He underwent a fine needle aspiration that showed medullary thyroid cancer. The immunohistochemistry was positive for synaptophysin, calcitonin, chromogranin, and TTF1. A serum calcitonin at baseline was more than 10,000. CEA was interestingly very low at 1.3, and plasma metanephrines were within the normal range. He had neck and abdominal pelvic CT scans showing a couple of left level 3 and 4 nodes up to 1.7 centimeters in size. And on the CT scans, there were no suspicious liver or bone lesions. The patient felt well. He was not hoarse. He had no dysphagia or dyspnea, no hemoptysis, no diarrhea, no flushing. His past medical history was notable for nephrolithiasis in his 20s, and he had no family history of endocrine disease. So he was referred to our center by email. I emailed the referring physician back and asked what his RET status was. And he said he's RET negative, but we didn't have the results of the RET testing available. So I responded back to him what kind of RET testing was done, and then I got a response, he's RET negative. So he was consented for genotyping. And so I wanted to ask the panel at this point, in terms of RET testing for this patient, what kind of RET testing should we be doing? Should we be doing germline RET testing in a patient who is a 74-year-old man and he has no family history that is suggestive of MEN2A or TB for that matter? And then should we be doing somatic testing at this point? So maybe Rosella, I can ask you.
Well, germline RET testing is important, and I would do it not for the man itself, not for the patient itself, because he's 70 years old. He already have a diagnosis of a medullary. But sometimes there are cases that are undiscovered, and you can find that he's harboring a germline mutation. And this is important for daughters, sons, nephews, so not for the patients specifically. At the same time, if the germline RET is negative, in a case like this, with this presentation, probably I will do also for a somatic test.
I totally agree. We have families with patients more than 8 years old with the germline mutation, with the medullary thyroid cancer, totally asymptomatic. So it's important to have also the germline.
Great, thank you. And then for somatic testing, how should we be doing that, Laura?
NGS.
And can we do that off of an FNA?
Yes. We can do it. I will start with a RET M918T just by PCR to have a very quick result, and then if negative, NGS.
Would you go ahead and do the NGS testing if the M918T PCR is positive?
No. Not me. No.
Yeah.
For a clinical reasons, no, I would stop, because to the recognition, the finding of an M918 is enough to start with the therapy. Then if I want to have a better view of the situation, of course, I would do an NGS.
Yeah. Okay. So we attempted NGS testing off of the FNA, but there was insufficient tumor testing. Tumor tissue available. So that assay failed. So what about surgery? Do you think that we should proceed with surgery in a case like this, or do we need to know more first? He's got bad local regional disease. He's surprisingly not symptomatic now, but he will be soon. Rosella?
I would discuss with the surgeon, and if the surgeon feels that he can afford the surgical treatment, I would proceed with surgery.
Okay. So we repeated the CT scans in May, and there was no change in the bulky disease in the neck and in the mediastinum. There were no new sites of disease that were appreciated, including no appreciation for distant metastases. So should we do another biopsy to do genotyping? Is it worth it to subject him to another biopsy, or should we proceed with treatment? We did review the case in our multidisciplinary clinic, and the surgeons felt comfortable in being able to do surgery in this case, but felt that there would be a high risk of an R1, if not an R2 resection, because of the impression of tracheal involvement.
I will do the genotyping, and as I said, maybe for a PCR, just for M918 is enough, the material from the FNA.
And how are you going to get more tumor tissue?
Another FNA of the patient.
What about a core? Did you do a core?
Maybe, yeah.
Okay. So that's what we did. We did a core needle biopsy, and when we put the presentation together, we didn't have the results back yet. So I'll share So if we find an HRAS mutation, which would be the most common somatic mutation seen if there isn't a RET mutation, what therapy might we consider? We're hoping that we can do neoadjuvant treatment, debulk the disease neoadjuvantly so that he can become a surgical candidate. So, Laura, how about if you, in your perfect world, you have every drug available?
Yeah. Every drug, but RAS mutation.
RAS mutation. Yeah, sorry.
RAS mutation, I prefer to start with vandetanib because the adverse events, in my experience, are less evident, less important.
Do we know, are there patients from the Zeta trial who had a RAS mutation and a confirmed response?
No, I don't remember in the Zeta trial. Maybe yes.
I think so.
Yeah, I think so.
I would definitely have to double check.
I think so. I will try first with vandetanib, if it is possible, because you know that now we have a restricted usage in Europe just for RET mutated cases.
And Rosella, in your perfect world, you have both frontline selpercatinib and pralsetinib available. And if there's a RET mutation found in this patient's tumor, how do you decide between the two?
Okay, between the two, I would choose selpercatinib, but just because I have more experience on selpercatinib, and according to the reported data, probably pralsetinib has a little bit of more side effects, but I have no great experience with pralsetinib. What I want to say is about systemic therapy first. I know that nowadays we are talking a lot about neoadjuvant therapy with these drugs. So I am still a little bit attached to surgical treatment, so I would start with the drug only if the surgeon would say that the surgical treatment is very difficult or not complete. Otherwise, I would start first with the surgery.
So, one of the differences in terms of the side effect profile between selpercatinib and pralsetinib is that there is a little bit more bone marrow suppression with pralsetinib, both with leukopenia and with thrombocytopenia. I think that difference in the side effect profile would impact on my choice if I was choosing one of these two RET-specific drugs in the neoadjuvant setting. And I think so. So since the slides were put together on my way to London, we did get the results back of his NGS testing, and we actually found two RET mutations at codons 630 and 666, as well as an ARID1A mutation. So, Rossella, what do you think about that genotype? I know you've published on compound RET mutations.
Yeah. Cases with compound RET mutations appear a little bit more aggressive, so we should even start earlier.
What do you think about the ARID1A co-mutation? And we talk about RET mutations and mutually exclusive RET RAS mutations in medullary thyroid cancer all the time. We don't focus too much on the presence of co-mutations, and we do see them sometimes.
Yes, we do.
And we talk about co-mutations with BRAF, E600E, and TERT, for example, all the time, but it doesn't come up so much in our MTC discussions.
Yeah, as I said, RET mutation different from point mutation like indels or double mutations are present in more aggressive cases. This is obvious.
And then what do we know about the efficacy of selpercatinib based on which mutations the patients have?
But in the studies, in the Libretto 001, it seems that there is no big differences. And we also reported our series of indels that they respond rather well.
Yeah. So on my way to London, I circled back with the patient's surgeon who felt that she would like to have as much help as possible in debulking the disease before taking the 74-year-old man to surgery. And because of the indication in the U.S. with selpercatinib and pralsetinib as being line agnostic and RET-altered cancers, we did choose to start him on selpercatinib, which hasn't quite started yet, but as soon as I get back home, I guess. That's it. Thank you.